right. Hello and good evening, and welcome everyone to today's webinar in the Public Health webinar series on blood disorders. This webinar is presented by the Division of Blood Disorders at the Centers for Disease Control and Prevention, also known as the CDC. I'm Dr. Robert Sidonio, and I'm a pediatric hematologist. I'm a director of clinical research and clinical operations for hemostasis and thrombosis at the Aflac Cancer and Blood Disorder Center at Children's Healthcare of Atlanta, which is part of the Hemophilia of Georgia Comprehensive Bleeding and Clotting Disorder Center. I'm an associate professor in the Department of Pediatrics, and I'm very delighted today to be moderating today's webinar for my friend and colleague, Dr. Veronica Flood. Our topic today is update on the diagnosis of von Willebrand disease. Before we get started, and before I introduce our guest presenter, I want to go over a few points and helpful tips for joining this webinar. All of you have probably well-versed in these webinars by now, but just as an update for this specific GoToWebinar. Upon joining the webinar, you'll see two audio options. You can opt to listen via your speakers on your laptop, or you can use your phone to call in. If the phone option is chosen, then the webinar toolbar will provide you with the phone and access number, and there will also be an audio pin. Those will also show up on the right-hand side. All audio will be muted during the entire presentation, except for Dr. Veronica Flood. At the end of the presentation, we'll allow time for questions. In the interim, you can submit your written question using the questions area of your toolbar. The presenters will respond to as many questions as time allows. We'll attempt to try to put them together and answer them as many as we can by the end of the hour. Today's webinar will last approximately 1 hour, and note that this webinar is being recorded. First, we'll begin today's webinar with two brief audience polls. All right, you can see this here. So which best describes you? And your options are listed there as healthcare provider, public health professional, person with a bleeding disorder or family member, industry, or community-based organization. Go ahead and try to answer the poll. All right, so you can see the breakdown here. Most of them are providers, as expected, physicians, nurses, staff members within HTZs. There's some epidemiologists. That's a lot of epidemiologists in there. So, for example, and there are a number of people that are within industry, community-based organizations. And so this is expected. We have, we'll go on to the next poll. So we just want to get an idea of which region you're calling from. Obviously, the time is a little later in the evening. I'll be really impressed if how many people are calling from Europe. But you see the options listed there: North America, South America, Western Europe, Eastern Europe, and Russia, Asia, Africa, Australia, or New Zealand. So we'll quickly answer that, and then we'll get started. All right. As expected, most people are from North America since this isn't on the afternoon. It's impressive. There are people from Asia, Africa, from Europe, South America, but nobody from Australia or New Zealand. So we'll have to work on that next time. So, all right. So let's go ahead and get started. It's my pleasure to introduce today's presenter. I think most of you know who she is, Dr. Veronica Flood. She's a professor of pediatrics in the Division of Hematology and Oncology at the Medical College of Wisconsin. She also serves as an associate medical director for the Comprehensive Center for Bleeding Disorders, as well as an associate investigator for the Recessive Blood Research Institute, also known as Blood Center Wisconsin for you those that don't know that they switched their name. Her interest lies in understanding the interaction between VWF, platelets, and the vascular endothelium. Her current R01 focuses on type 4 collagen and its role in von Willebrand and platelet interactions, and she's one of the lead scientists in the Zimmerman program for molecular and clinical biology of von Willebrand, which is an NIH-funded program. So Dr. Flood, welcome, and let's begin.
Thank you so much. I would like to specifically thank the CDC's Division of Blood Disorders. I really appreciate the support and the opportunity to speak today, and then of course thanking HFA for their support of this webinar. I'm excited to get to talk to you guys about some of our data, and I also included some background information since it sounds like we have a fairly broad audience. I have no conflicts of interest to disclose. So there's a couple of goals for this presentation. I wanted to go over the range of presentation of von Willebrand disease, primarily in the United States, and this data would also apply to Europe. To understand the laboratory criteria for diagnosis of von Willebrand disease, which is often a moving target, and then for people to understand the difficulties in von Willebrand disease laboratory testing. I don't know that I'm offering a lot of solutions today, but at least highlighting some of the issues that are the reason why this is such a fascinating disorder and so challenging to diagnose. And I also want to give a shout out to my fantastic mentors, Bob Montgomery and the late Joan Gill, for everything they've taught me so that I can present here today. So von Willebrand disease is the most common inherited bleeding disorder that no one seems to know about. Hemophilia gets all the attention. Von Willebrand disease is actually more common. About 1 in 1,000 people have symptomatic von Willebrand disease. Women are diagnosed more often than men, and this is primarily due to their ability to present with heavy menstrual bleeding. And von Willebrand disease typically presents with mucosal bleeding. So this would be bleeding such as nosebleeds, bruises, heavy periods, bleeding with surgeries. Although I do want to recognize that patients with type 3 von Willebrand disease can present with joint bleeding, and there are some specific types, especially type 2A, where GI bleeding is a prominent source of bleeding. Von Willebrand Factor is a huge protein. It is a very large, long protein with lots of subunits. It is a multimeric protein that is shown here in this beautiful EM from Evan Sadler. Von Willebrand Factor has several functions. It serves to bind platelets through platelet glycoprotein 1b, and this will be important in some of the tests that we're going to be talking about. It binds injured endothelial cells through collagen, and then it binds factor VIII and protects it in circulation. The genetics of von Willebrand Factor are as complicated as the protein. Vwf gene is located on chromosome 12, and it is 180 kilobases in length. This comprises 52 exons and 2,813 amino acids. So when we talk about the genetics of VWF, you can already see that with all the space to have issues, there's a lot of room for variation. There are key areas of the VWF protein that are diagrammed here. So the area highlighted in green is the region that is responsible for binding to factor VIII. The A1 domain, which is the region highlighted in blue, is responsible for binding GP1B. It also binds several types of collagen, specifically types 4 and 6. The area highlighted in the pink or purple color is the A3 domain, and that is where collagen types 1 and 3 bind, and this is the area that most of our collagen testing that is commercially available will cover. The diagnosis of von Willebrand disease is typically based on 3 criteria: a personal history of bleeding for the patient, a family history of bleeding or family members who carry the diagnosis of von Willebrand disease, and then labs showing low von Willebrand factor. And probably the most important features here are the fact that this patient would have both of the personal history of bleeding and the lab showing low von Willebrand factor. And so these are the areas that I'm going to be talking about further, how we determine somebody has a history of bleeding, and then how we determine somebody has truly low von Willebrand factor. The baseline problem is that bleeding symptoms occur in healthy individuals. This is data from Natalia Ridds and Paula James that was published a few years ago and compares symptoms in normal people versus patients with von Willebrand disease. And they actually went through and separated into type 1, type 2, and type 3 von Willebrand disease. And just comparing normal individuals and patients with type 1 von Willebrand disease, you can see that nosebleeds are far more common in von Willebrand disease, bleeding post-dental extraction, bleeding from minor wounds, and post-surgical bleeding. But there are some areas where there is overlap. For example, menorrhagia or heavy menstrual bleeding, hematomas, and even postpartum bleeding, there's a little bit of an overlap in patients. So how do we deal with bleeding symptoms being common, yet more common in von Willebrand disease? Well, one way to do this is through bleeding scores. Bleeding scores are a standardized way to measure bleeding symptoms. There are many scoring systems available, and there's actually been an evolution of these bleeding score systems. But in the interest of time, I'm going to present the one that may be used most commonly right now, which is the ISTH Bleeding Assessment Tool. This is a measure that looks at a variety of areas of bleeding. There are questions about epistaxis, cutaneous bleeding, bleeding from minor wounds, oral cavity bleeding, GI bleeding, hematuria, tooth extraction, surgery, menorrhagia, postpartum hemorrhage, mesohematomas, hemarthrosis, CNS bleeding, and then other bleeding. And for each of these questions, patients are assigned a score. And this next slide shows the bleeding assessment tool scoring for several areas: epistaxis, bruising, and bleeding with surgeries. If a patient has no symptoms, they get a score of 0. To take the top row, nosebleeds, for example, if a patient has more than 5 per year or the nosebleeds last more than 10 minutes, they get a score of 1. If the nosebleeds led that person to consult with a physician, they get a score of 2. If they required intervention, such as packing, cautery, or an antifibrinolytic, they get a score of 3. And then if they required blood transfusion or desmopressin or some other replacement therapy, they get a score of 4. So basically, for each symptom, the more severe it is, the higher the score. A score of 0 means a person has no bleeding whatsoever. There's also a self-administered bleeding assessment tool, and these are scored as a normal child, a normal adult male, or a normal adult female. So in children, which the studies have defined as children are less than 18, a score of less than or equal to 2 is considered normal. For adult males, a score of less than or equal to 3 is considered normal. And for adult females, a score of less than or equal to 5 is considered normal. And as you can see in the sensitivity and specificity, for women at least, this is a very sensitive tool and has a great negative predictive value, meaning if you have a score of 0 or 1, you can fairly confidently say this person does not have von Willebrand disease. The problem comes in pediatrics when patients have not experienced much in the way of challenges. It's hard to know if they've had no bleeding because they don't bleed, or if they've had no bleeding because they've never had surgery, they're not old enough to be getting their period, etc. The other area that's a little difficult is teenage females who have started to menstruate. They may have a normal score for an adult female, but an abnormal score for a child, and we may see more work in this area coming out. But for right now, this is a scoring system, and it does allow us a way to quantify how much bleeding people are having. In clinical practice, this is helpful because you may have 2 patients that complain of nosebleeds. One person gets a nosebleed once a month that lasts for 2 or 3 minutes. The other person gets a 30-minute nosebleed once a week. So obviously these 2 patients are probably not having the same bleeding experience, yet their chief complaint may be identical. Using these bleeding assessment tools in clinical practice, people have shown, this is data from Mackenzie Bowman and colleagues, that the increased bleeding score correlates with increased von Willebrand disease severity. So these are bleeding scores in this graph from type 3 patients on the far left, type 1 patients with a slightly lower median bleeding score, and then the UFM is unaffected family members on the far right. There's also some data from Augusto Federici and colleagues that suggests that bleeding score may predict future bleeding. A bleeding score of greater than 10 is highly predictive that that patient is going to go on to experience bleeding complications in the future. But as I mentioned, children remain a challenging population, particularly very young children who really haven't had any challenges to date. This graph shows bleeding symptoms in type 1 von Willebrand disease and is taken from a recent paper by Michelle Levin and colleagues from Ireland, where they show that the bleeding symptoms across a spectrum of patients with type 1 von Willebrand disease, and specifically with levels between about 30 and 50. And if you The red and the blue are just looking at two different bleeding scores. So if you focus just on the red bars, you can see that menorrhagia contributed to a bleeding score in a very high proportion of individuals. The next highest was dental bleeding, then postpartum hemorrhage, bleeding with surgery, nosebleeds, cutaneous bleeding, and then bleeding with minor wounds, as well as epistaxis. So these are common symptoms that were found in their population of individuals with mild von Willebrand disease. If you go across to the far left of the graph, CNS bleeding and hemarthrosis, which we often see in patients with hemophilia, were very rare in this population. And again, this is specific to type 1 von Willebrand disease. If you're surveying a population of patients with type 3 von Willebrand disease, you might see those becoming more frequent. So to summarize the bleeding assessment data, the ISTH-BAT or other bleeding scores can be used to quantify bleeding symptoms. The bleeding scores, I think, are most helpful in reducing the numbers of patients who require workup. If somebody has a normal bleeding score, that may be somebody who doesn't need all this fancy testing. The high bleeding score may predict future bleeding episodes, but there is still a role for clinical judgment still being required. And again, this is particularly in pediatric patients or patients who haven't experienced a lot in the way of challenges. It's also helpful in looking at patients with high bleeding scores because these are patients in which we may want to recommend that they receive more testing. And I think I have this later, but all bleeding is not von Willebrand disease. So this talk is focused on von Willebrand disease, but there are definitely other things that can cause bleeding and high bleeding scores. Okay, so moving on to laboratory testing. I think this is one of the huge challenges in the clinical diagnosis of von Willebrand disease. The biggest problem is that there's no single screening test for von Willebrand disease. There's no simple confirmatory test available. Repeat testing may be necessary because lots of different conditions affect Vwf levels. Stress can raise your level, and we always worry about this in young children, but it could in adults. Hormone therapy, some hormone therapies may affect it. Some medical conditions, if you're highly inflamed, that can increase your Vwf levels. On the other hand, hypothyroidism and some seizure medicines can reduce your Vwf levels. So a single normal, especially if it's a low normal, does not necessarily rule out von Willebrand disease. A high normal result, on the other hand, is probably much more helpful at ruling it out, and there's some recent data from the Philadelphia group on this. There are some people that have low Vwf levels, but no bleeding. So we know from work by Dr. Galen Montgomery a few years ago that patients with blood group O have low von Willebrand factor levels, but not all of those patients will experience bleeding. Not all doctors are aware of von Willebrand disease or how to diagnose it, and other bleeding disorders can look like von Willebrand disease. So platelet disorders, for example, platelet function defects can present with similar bleeding like nosebleeds or heavy menstrual bleeding. So what do we do for laboratory testing? Generally, patients will receive some combination of a von Willebrand factor antigen, which is a measure of total protein, Vwf activity, which measures von Willebrand factor binding to platelets, particularly to platelet glycoprotein 1b, and factor VIII activity, since Vwf serves as a carrier protein for factor VIII. Because Vwf is a multimeric protein, many people will also look at Vwf multimers, which are reduced in type 2A and 2B von Willebrand disease, collagen binding, which can be a surrogate for the distribution of multimers, or Vwf genetic testing, and we'll talk more about that in a little bit. So the Vwf activity in the United States has historically been the Vwf ristocetin cofactor activity. This is where we take the antibiotic ristocetin and use it to help Vwf, particularly the A1 domain, bind to the GP1b alpha on the exposed platelet. So the first problem is that this assay is non-physiologic. In vivo, it's sheer stress that initiates the Vwf platelet interaction. There's a high coefficient of variation. There's some data from the early 2000s showing it can be up to 50% between laboratories. So basically, if you want to diagnose someone with von Willebrand disease, just keep repeating their ristacine cofactor activity, and eventually you'll get a low level. It's also problematically affected by sequence variants in the VWF-A1 domain. The most common one of these is the PD1472H variant, which is associated with an increased antigen and a decreased ristacine cofactor to antigen ratio. And I'm going to show you some of our data on this particular variant. So this is data from a group of healthy control individuals enrolled in the Zimmerman program. So these are people that came in as controls, no history of von Willebrand disease. And there was a number of different ethnicities, but we had a proportion that were Caucasian and a proportion that were African American or Black. This data is for all the controls split into whether they had the 1472H variant on the left or they had the wild type, which is the D allele only. And as you can see, the ristacine cofactor to antigen ratio for the group without this variant was very close to 1. It was 0.96. For those with the variant, either 1 or 2 copies, the mean ratio was 0.77. And when we're diagnosing type 2 von Willebrand disease, many people will consider a ratio of less than 0.7 to be abnormal. Here I've just chosen 0.6 to be more conservative. Even there, though, you can see that a number of these healthy subjects had ratios that were less than that cutoff. And therefore, if they'd been going in for testing for a bleeding disorder, would have been diagnosed with type 2 von Willebrand disease. There's also a dose response to the number of the 1472H alleles. We did not have any Caucasians that were homozygous for 1472H, so this is looking only at the African American or Black individuals. And you can see that the lowest ratio was in those that were homozygous for the H allele, with a mean ratio of 0.66. The heterozygotes had an intermediate ratio of 0.79, and those that were homozygous for the D allele had a mean ratio much closer to 1 at 0.91. And I hesitate to call it the wild type allele because what we think is that either of these are equally normal. It's just that one gives you an artificially low ristacine cofactor activity. So this is fairly common. This was about almost 20% of our African American individuals, of our Caucasian individuals, and over 50% of our African American individuals had this variant. So this is a not uncommon issue that comes up potentially in clinical practice. So how can we get around this? So there have been several groups that have looked at getting rid of ristacine. And so I'm going to present the data that Dr. Montgomery and his lab came up with on their assay first, and then some data on a commercial assay that's now available. So this is using a gain of function GP1B alpha, and our original version was using an ELISA, which took the GP1B alpha and put in platelet type von Willebrand disease variants. So when you have a gain of function in the VWF that causes spontaneous binding, that's type 2B von Willebrand disease. When those variants are in the GP1B, it's platelet type von Willebrand disease because the problem is in the platelets. So what we did was change the residues in pink and in orange here from the wild type, which was D235 and M239, to a tyrosine and a valine, respectively. The construct was truncated at the transmembrane domain because we didn't need it to stick in a platelet membrane, and then a mutation inserted to prevent dimerization. And this was used without ristacine as a way to bind von Willebrand factor. The assay gave similar results to the antigen when we looked at all our healthy controls. So the antigen, we had a mean of 109. With this GP1BM assay, we had a mean of 102. The ristacine cofactor activity was lower, again, probably because of the subjects that had the 1472H variant. So there was a statistical difference between antigen and ristacine, but not between the VWF antigen and the GP1BM activity. And this activity assay was not affected by 1472H status, unlike the ristacine cofactor activity. So on the right, you have the ristocetin data using either those with only the wild type allele, which is the 1472D, or those who were heterozygous or homozygous for the H allele. In contrast with the GP1BM assay, the results were basically identical. There was no difference whether or not you had this 1A1 domain variant. The assay that uses a gain-of-function platelet GP1B, ISTH has now recommended we use the terminology VWF GP1BM to represent that assay. So this is very encouraging that we don't have that same issue. Siemens has an automated activity assay that, again, does not use ristocetin. It uses a gain-of-function platelet protein. It's got two slightly different platelet type von Willebrand disease variants in it, but it's the same exact concept that you allow spontaneous binding between the GP1B alpha, which on their assay is attached to a microparticle, and the patient's von Willebrand factor, specifically the VWF A1 domain. The one nice feature is that it's not affected by the 1472H variant. The other nice factor is that these assays have less variability and are more precise. So instead of repeating the ristocetin multiple times and getting completely divergent answers as to somebody's von Willebrand factor activity, if you repeat this assay, you will generally get numbers that are very close to each other. So this can give you more confidence in the values that you're getting. This is important for several reasons. So we need a von Willebrand factor activity to rule out type 2 von Willebrand disease variants. In type 1, you have a concomitant decrease in the antigen and the activity. So they'll be parallel. And in type 3, they're absent, so they're parallel but absent. But in type 2, there's a discrepancy between the antigen and activity. If you just measure an antigen, you may miss those type 2 variants. On the other hand, if you measure an activity and it's artificially low because the assay isn't so good, you might diagnose somebody with type 2B von Willebrand disease or some type of type 2 von Willebrand disease, and then have them treated with VWF concentrate, when generally those are patients that you could have gotten away with treating just with desmopressin. You might end up making different recommendations for their future sports activities, their future health. So it's very important that we get an accurate activity assay. Measurement of VWF activity using the gain-of-function GP1B alpha assay is feasible and reduces the issues with ristocetin. As I said, ISTH is recommending using the term VWF GP1BM, meaning it's a GP1B that has a mutation in it, for assays using the gain-of-function GP1B. And there's a version of this assay approved in Europe and Canada. It's the Siemens Innovance activity. Versity offers the ELISA version of our GP1BM, but I think many hospitals are still running ristocetins. So it's important to be aware of the limitations of any assay that you're running, but particularly when you're evaluating somebody for von Willebrand disease, particularly being aware of the limitations of the ristocetin activity. I would be remiss if I didn't also mention the pre-analytical side of this. There's a brand new paper out by Julie Jaffrey and colleagues that highlights the variability between labs drawn at outside institutions and labs drawn at hemophilia treatment centers where they're used to running coag labs, and the discrepancy in a number of patients that had low levels with outside laboratory testing that were referred in and had normal test results. So like factor 8, VWF does need to be kept in a nice environment. There's a very old paper, Misdiagnosis by Milkbox. When samples were put in a very cold environment, you get cryoprecipitate and measure a low VWF and low factor 8. When samples are handled properly, then this isn't an issue. But it's always important when you get results that don't seem to match with reality, it could be something that happened with the blood sample even before it got to the lab. Okay, so moving on to some of our data. So what I most want to talk about is type 1 von Willebrand disease, because I think that's the area where there's the most interest right now. In 2007, the NHLBI published a paper suggesting true von Willebrand disease was only for people with levels of less than 30. Low VWF may be more of a risk factor for bleeding than a diagnosis, and this is a concept championed by Evan Sadler, and here he shows what a normal VWF distribution looks like in the population. If the mean is around 100, there's going to be people that are lower, and there's going to be people that are higher. We know that individuals with super high von Willebrand factor may be more at risk of thrombosis, and then those with super low von Willebrand factor have type 3 von Willebrand disease or a severe von Willebrand disease form. Those with mild decreases, maybe this should be considered more of a risk factor. Similar to how we consider factor V Leiden a risk factor for thrombosis, maybe these slight decreases in VWF are more of a risk factor for bleeding rather than calling them a disease. But patients with low VWF do experience bleeding and do benefit from treatment. So I want to show you our data from the Zimmerman program. This is a NIH-supported program project grant where patients were enrolled from centers across the United States. And I've listed the primary centers, of which Atlanta very kindly was a primary center, along with the other ones listed here, and 20 secondary centers across the U.S. The patients enrolled had to have a pre-existing diagnosis of von Willebrand disease, although this could be any type, and central laboratory testing was then performed when the patients returned to clinic after their diagnosis had been made. So sometimes fairly short after the diagnosis had been made. Some of these were patients that had been diagnosed many years ago. And the samples were all run at the Versity, or formerly Blood Center of Wisconsin, Hemostasis Laboratory. So a number of different pieces of data were collected. Laboratory testing included VWF antigen, ristocetin cofactor, collagen binding, propeptide, and multimers. Factor VIII and originally blood type were measured, as well as some additional research laboratory studies, including the GP1BM assay that I mentioned earlier. Bleeding score was obtained for all subjects using the ISTH bleeding assessment tool with some additional questions specific to the Zimmerman program. And then full-length gene sequencing was obtained for all of the index cases and for the healthy controls, including the promoter region and including intron-exon boundaries. This is important because we now know from looking at healthy individuals that there's a lot more variation in the VWF gene, and I will get to that. Okay, I did want to outline how we assigned VWF types, just in case there's any learners in the audience. For type 1 von Willebrand disease, this was a VWF antigen or ristocetin cofactor or GP1BM less than 30. We did have a category for this low VWF where the VWF was greater than or equal to 30 but less than the lower limit of normal. Patients with type 2A von Willebrand disease had an activity to antigen ratio less than 0.6 and loss of the high molecular weight multimers. Type 2B was similar, except these patients also demonstrated increased spontaneous platelet binding. Type 2M was an activity to antigen ratio less than 0.6 with normal multimers. Type 2N, they had to have low factor VIII and abnormal factor VIII binding. And then type 3 was undetectable von Willebrand factor levels. Okay, so the data I want to look at primarily centers around this low VWF cohort. This is our von Willebrand disease patients with a diagnosis of type 1 or low VWF, sorted by their von Willebrand factor antigen and compared to that control population that I mentioned earlier. So this first graph shows the data for subjects with an abnormal bleeding score in dark gray and a normal bleeding score in light gray for antigens less than 10, 10 to 19, 20 to 29, 30 to 39, 40 to 49, more than 50, since some of the subjects did have antigens higher than that typical cutoff, and then for the healthy controls. And you can see that very few of the healthy controls had an abnormal bleeding score, only 2%. The patients or the subjects with very low VWF had very high bleeding scores, 70 to 80% generally. But this middle group, those with levels of 30 to 50, and even those with a diagnosis of type 1 who happened when they came back in to have antigens greater than 50, still had very elevated bleeding scores when you compare them to this normal population. Here we're talking at least 2/3 had an abnormal bleeding score when they were enrolled into our study. So this suggests that there's not a dramatic difference when your VWF level crosses from 20 to 30. It suggests that bleeding can occur in association with low von Willebrand factor. Now, I will admit that this does not say that that bleeding is causative. You could argue that perhaps some of these low VWF patients, particularly this group, had other reasons for their bleeding, but it is an argument for treating their bleeding as different than the healthy controls. Bleeding is common in low VWF status, so here is just the distribution of bleeding scores comparing normal on the far right in the purple, where the median bleeding score is 1, which is totally normal, to the low VWF with a median bleeding score of 4, and the type 1 with a median bleeding score of 5.5. And you can see both of these groups have a large number that trail off having bleeding scores greater than 10, although admittedly there's also patients who have bleeding scores that are 1 or 2 or even 0. And I should say one of the hallmarks of this study, since a number of the centers were pediatric, it is weighted more towards pediatric patients, which may be what's bringing these median bleeding score numbers down. So patients with type 1 von Willebrand disease and patients with low VWF had similar bleeding scores, and both were substantially higher than the bleeding scores seen in healthy people. In looking at the genetics, there was a decreased frequency of sequence variants in the low VWF subjects as compared to those with more severe type 1 von Willebrand disease. So this is the same groupings of VWF antigens for the type 1 and low VWF subjects. The dark gray is those with a sequence variant. The light gray is those who did not have a common or a rare sequence variant in their VWF. I do want to highlight for a minute, though, this control population. So admittedly, we had enhanced our control population for African American or Black subjects, but looking at those controls, 14% had a sequence variant in their VWF. That was fairly uncommon. Anything that was at more than 1% of the population, we didn't count as a sequence variant. So this is a fairly high number. It's certainly much more common in the African American or Black population, but it really does speak to if you find a new change in VWF, that does not automatically mean it's pathogenic. I think when people first started doing DNA sequencing, anytime they saw a change from what the quote-unquote normal was, it was considered to be a mutation that was causing disease. Now we're finding out that some of these mutations don't necessarily do anything. They're just a sequence variant that's there, but it doesn't change the function of the protein. You can also see in the patients or subjects with VWF antigen greater than 50 that only 20% of those had a sequence change in VWF. So looking very similar to the controls. On the other hand, at the extreme end, those with antigens less than 20, we had a very high frequency where a probable causative variant was found. 74% in the 20 to 29 group, and then we fall off to 58 and 64% in the 30 to 50 group. And this is similar to data that's been shown in multiple other studies. So genetic changes in VWF are not universal in type 1 von Willebrand disease. This is 5 different studies, UK, European Union, Canada, US, and Germany. On average, it's 2/3 of the patients enrolled in these studies have sequence variants. So that is 1/3 that don't. And I think this is important because there's a lot of diseases where genetic testing has become the go-to for how to diagnose a condition. And I want to highlight this because in type 1 von Willebrand disease, we have patients with low VWF that do not have a sequence change in their von Willebrand factor. Is this semantics? Does this mean they don't have von Willebrand disease? I don't know that I don't have the answer to that, but I would be very cautious at using VWF gene sequencing to clear a patient from a diagnosis of von Willebrand disease. And then the other side of that coin is that you may come up with variants that don't mean anything and give somebody an unnecessary diagnosis. I want to take 1 minute, since time permits, to highlight some of the pathogenic mutations that are coming out that are not part of the VWF gene. So one of those is the ABO blood group. And again, Joan Gill showed this 30 years ago, that type O is associated with lower VWF levels. We've also seen this in children, that children can have lower VWF levels, and we know levels increase with age. There is a lot of interesting data that's come out of large genome-wide association studies of other areas that affect VWF level. So CLEC4M is a receptor that binds and clears von Willebrand factor. If you have variants in CLEC4M, you may have increased clearance of your VWF and fall into that low VWF or type 1 category based on a variant in a gene that works with VWF, but that isn't VWF. SCARA5 is a scavenger molecule, and that's also been implicated in von Willebrand disease, as have stabilin-2, syntaxin binding protein 5, and there's a host of others that are being investigated as we speak. So there's some extragenic, outside the VWF gene, reasons that people could have low VWF. Now, this isn't a talk on treatment, so right now, the treatment of all of these is exactly the same, but this does pose an interesting question for the future, if there'll be ways of treating patients differently if they have one of these other modalities that's causing their low VWF versus a genetic defect in their von Willebrand factor gene. So, in conclusion, I just want to call back to the beginning in that bleeding scores can be very useful in quantifying bleeding symptoms. And one reason for this is because you don't want to be sending a workup on somebody who doesn't have von Willebrand disease, given the high likelihood of getting an abnormal result with those risdipine cofactor assays. The VWF GP1BM may provide more reliable assessment of VWF platelet binding activity, and I know it's not available at this point throughout the US, but there are a number of labs in Canada and in Europe that have moved towards performing this. This isn't a cost-effective analysis either, but it may be more expensive. On the other hand, repeating von Willebrand testing 5 times while you're looking for a diagnosis probably isn't cost-effective or improving anybody's quality of life. Many individuals with slightly decreased VWF levels experience bleeding. So I don't know that I would be in favor of having an arbitrary cutoff, but more investigating individuals and their bleeding symptoms in that specific context. And then especially in this era of whole genome sequencing, it is very important to recognize that not all low VWF is caused by genetic variants in the VWF gene. I want to take a moment and thank all my Zimmerman program collaborators, especially my fantastic mentors, Bob Montgomery and Joan Gill, our fantastic lab that does all these assays, and then I present these graphs, particularly Pam Christofferson, Patty Moratak, and Crystal Perry. And I want to thank the NIH for our funding. I believe I did leave some time for questions, so please type them in the appropriate box. And thank you so much for your attention and the opportunity to present today.
Yeah, thank you very much, Dr. Flood. What a great presentation. And as she mentioned, we're going to go ahead and shift to the question and answer section. We've received a few questions, but to go ahead at this time, this would be a great time to submit your questions in the area of the toolbar. They'll be screened and be sent to me for review. Again, this webinar is brought to you by the CDC's Division of Blood Disorders, and we want to thank Hemophilia Federation of America for hosting today's webinar. And the information there is if you have any questions, and it will soon be archived after this presentation is complete. All right, are you ready, Dr. Flood?
Ready.
Okay, all right, we'll start with this one. So as you remember, there were people from all over the world listening in, and so this one comes from South America. So the question is, how difficult, and maybe they know this answer, are there other assays if you don't have the availability of assays such as risdipine cofactor, GP1BM? Maybe you only have the antigen and factor VIII in some global assays. how difficult is it to make appropriate diagnosis of von Willebrand disease?
Yeah, that's a great question. So the vast majority of type 2A individuals will have a low antigen as well. The problem is going to be figuring out if it's a type 1 or a type 2 variant in that case. The collagen binding assay is fairly easy to do, and that will give you a rough assessment of multimers. So multimers are run out on a gel to look at the different molecular weight multimers. It's a process that takes a couple days and lots of reagents. So that probably isn't translatable. The collagen binding assay, though, can be done either automated or via ELISA, and so that could be a potential substitute that would at least get you multimer assessment to put it in a type 2A or 2B versus a type 1 category.
Great information on how to set up a lab.
If you're going to run one assay, people would argue that the activity might be more important. Ristocetin is challenging, and I completely understand their predicament, but that's my suggestion.
It's tough. Yeah, it's tough. We've always say it's easy to diagnose severe von Willebrand's. It's very difficult to diagnose mild, and it takes a lot of expertise. So good luck to that questioner. All right, the next question here. So in patients with levels in the low VWF range, specifically 40 to 49, you mentioned that about 68% had a sequence variant that was found. Were these? The question is, I guess it says there was a sequence variant. Were all of these considered pathogenic? I know you alluded to that a little bit on how you decided what was a sequence variant.
Yeah, so we're still going through all the individual variants and putting them through the algorithms that let you say, probably pathogenic, possibly pathogenic. So some of them may not be. There's also the flip side to this, which makes the genetics much more complicated, of the potential for some of the common variants to be interacting with other things and causing low VWF. There's some great data out of Canada and then out of the WIN study from the Netherlands linking these CLEC4M and then I think it's the sibyllin binding protein variants with low VWF as well, and we have not sequenced those. So I'm guessing the numbers will be slightly lower of those with a truly pathogenic variant in something that's affecting the VWF, but that could be across the board because some of these variants may be caused from problems with proteins outside this.
Oh, great. So the next question, moving along, I think this was brought up during ISTH, and it may be addressed in other papers later this year as well. But the role of genetic testing, you discussed that in type 1, there's not as much of a role in genetic testing outside of severe von Willebrand's. What are the subtypes specifically do you feel that genetic testing plays a large role? And the question they had was about type 2B. Do you think that is one of the ones in which you should consider targeted exon sequencing?
Yeah, that's a great question, and you're getting my biased opinions here, so I should have put that caveat before any of these answers. And Dr. Sidonio can reply to this one too, but I really think it's the type 2 variants that this is much more useful in. Distinguishing 2A from 2B can be difficult if you don't have specialized assays available, and there's very specific and well-known type 2B genetic variants out there. If you do sequence, it's just exon 28, that A1 domain, and hit one of those, you've made your diagnosis. If you don't get one of those variants, then you've pretty much excluded that it's type 2B von Willebrand disease. So I would be very comfortable with that. 2A is a little harder in that there's more novel variants that are causing type 2A, but as far as treatment goes, if you're pretty sure the patient is type 2 and your question is how safe do I feel using desmopressin, I think sequencing can be a great option.
Yeah, I totally agree because you're making treatment decisions based on the genetic testing. Other than being really interesting, I think there's a role there. So yeah, I totally agree. So can you speak a little bit about the
Yes.
inheritance? I know you didn't focus on that. Somebody was asking a little bit about the differences in inheritance.
Sure. So type 3 von Willebrand disease is autosomal recessive, meaning that you need to have 2 dysfunctional VWF genes in order to have type 3 von Willebrand disease. The type 2 variants are generally autosomal dominant, as is type 1, with the exception of type 2N, which drives everybody crazy in trying to explain. You can either have the classic Normandy, 2N, the N is for Normandy, France, where the first paper describing this came out of, or the first recognition of it, I guess, because Dr. Montgomery has an earlier paper that describes that phenotype. But the N is for Normandy, where those patients are autosomal recessive in that they have 2 type 2N variants. In the United States, and probably in some other parts of the world, the more common way to get type 2N is to have 1 type 2N allele and 1 type 1 allele where there's very low expression. So your functional VWF that's coming out is all the 2N phenotype VWF, but the genetics are going to be type 1/2N, if that makes sense. And I'm waving my hands around, and I realize no one can see me, so please email me, and I'm happy to diagram it out for you.
I think Dr. Montgomery's the only one that loves explaining the type 2 invariants. So
it's like all of VWF, it's not straightforward. And the inheritance, you should say that's the genetics of it. The inheritance, what type 1 is usually called, is autosomal dominant with variable penetrance, meaning that if there's a genetic mutation, everyone has it, but their levels can be very different and their phenotypes can be different. Some of this may be due to the other genes that are involved. You know, hypothetically, you could have a father who's had very minimal challenges, who has Vwf levels in the 40s and doesn't bleed. He has a daughter who has problems with heavy menses because of those same levels. So it is more complicated, and it's a good reason to leave it off my slides, but I guess not a good reason not to try and explain it. So thank you for the question.
All right, there's a lot of questions about the activity assays. Obviously, we all see us moving further away from the ristocetin-based assays, probably more toward these GP1BM type assays. So obviously one of them, as you mentioned, is the Siemens assay. I know there's been some issues on making these more widely available. Right now, as it stands, it's obviously available, the ELISA version that you have in Versiti. But the Siemens assay, which I think was out of a German group, is that an assay ever going to be available in the United States, or the version that you guys have developed?
I would hope that there will be an assay available for marketing throughout the U.S. I don't have any inside information, so if anybody from Siemens or the FDA is listening, I think this is one of the challenges in that patients get diagnosed with type 1 based on one super low ristocetin, or they get diagnosed with type 2 based on a low ristocetin, but they really have type 1. And I'd encourage everyone to look at Julie Jaffrey's paper that's in Press with the amazing number of patients that had abnormal lab values the first time and then that were normal the second time. It's worrisome that we're overdiagnosing or misdiagnosing. So I hope that this will be more widely available. It may not be the top priority right now with everything else that's going on, but hopefully someday.
All right, we got a couple more minutes. I'm going to try to find some that I think we should probably answer. Can you speak a little bit about, you spoke about the different subtypes, and as you know, there's multiple different variants, specifically about type 1C or Vicenza type. Can you speak to that a little bit, of just sort of the generally of how it's diagnosed and such?
Yeah, so this, if you're thinking about von Willebrand disease in terms of diagnosing what's going to make a clinical treatment difference, I think type 3 is not a diagnostic challenge. They have no VWF. The question is this a patient I can give desmopressin to, or is this a patient that needs a von Willebrand factor concentrate? And most type 1s will respond to desmopressin. The one exception is this subtype that I think at ISTH it was proposed to officially classify it as type 1C. The pathognomonic variant that first was reported is this Vicenza variant. That's one specific variant that causes increased clearance of VWF. So the VWF is made, but the reason that there's low levels is that it's cleared very, very, very rapidly. So one way to diagnose this is by doing a desmopressin trial, giving somebody desmopressin and measuring it not just immediately afterwards, but a few hours afterwards. These patients with increased clearance, their levels will go up, and they actually usually go way, way up. But in a couple hours, they're back down to their baseline. So this one is important to know about because generally we would not recommend giving those patients desmopressin to cover for a major surgery because we know their levels are going to be back in the gutter a couple hours after you give it. So that's why it's important to make that diagnosis. You can do a von Willebrand Factor propeptide. That will be elevated in these patients, but you can also do a desmopressin trial and do a late time point to make sure you're accounting for the survival, and if that's low, then you have a diagnosis. But I do think that's an important subtype to call out because of the potential need for different treatment, just like the type 2 variants.
That's great. We'll squeeze in one more question. Can you talk about the timing of testing in a woman that has postpartum hemorrhage that has not been identified as having von Willebrand, and maybe make a sort of a comparison to someone that has heavy menstrual bleeding?
Sure. So caveat, I'm a pediatrician, so I try not to see patients with postpartum hemorrhage if I can help it. But I think this question just gets to the role of hormones. So what happens to von Willebrand factor is that it increases in a normal woman throughout pregnancy. It will also do the same in a type 1 patient, increase throughout pregnancy. It's highest at delivery, and then the levels crash back down. So if Robert, actually, you might have this data for adult women, but I would think in the setting of postpartum hemorrhage, it would just be like our girls that present with heavy menstrual bleeding. If they're super stressed, you could get a normal or low normal value, and that would be a situation where if they had a lot of bleeding, I would really want to repeat when they're in their usual state of health. Most of today's hormones do not hugely affect the levels. So it's really just a matter of how high they are. You know, if they're 300, I'm not that excited. If they're 56, I might repeat it.
Yeah, I agree. It's just repeating it at a time later when you're seeing them maybe a few months later. That's sort of been what we've done here for those patients with heavy periods. And certainly that's what Andy James, I think, has shown in her work in von Willebrand. So. All right. Well, we're at that time at the end of the hour. I'd like to thank Dr. Flood for providing us such valuable information on the latest in the diagnosis of von Willebrand disease. I want to thank each of you for joining us for this talk. And we want to thank our colleagues at the CDC's Division of Blood Disorders for this invitation today, and for HFA, or Hemophilia Federation of America, for hosting this webinar. Very shortly, you'll receive an email link asking for your feedback. We want to hear from you. We want to hear what you want to hear about next. And if you have any questions about that, please contact Cynthia Sayers at csayers@cdc.gov. Thank you very much, and have a good afternoon.
Thank you all.